Well, welcome everyone. I would like to thank you all for joining us for the March 27th Board of Health meeting here at the Spokane Regional Health District, and we're just starting a couple minutes late. So thanks for being here, and we'll start with the roll call of board members and our leadership. So I will start by saying I'm County Commissioner Amber Waldreth, your chair, and we'll start with Mr. Commissioner Kearns. If you can just do introductions around the room.
Josh Kearns, County Commissioner.
Charlie Donona, representing community stakeholders.
Mary Cuny, Spokane County Commissioner.
Dr. Velasquez, Health Officer.
Alicia Thompson, Administrative Officer.
Councilmember Michael Cathcart, representing cities and towns, and Vice Chair.
Michelle Fossum, Legal Counsel.
And Pittsnogle, Recording Secretary.
Wonderful. So just a reminder to hit the right hand, our fancy new microphones, the right hand button with the little person talking, and that will put you on or off your microphone. So if it's red, it's on. If it's not red. And we try not to, we can't have more than 6 microphones on at a time, so just remember to turn off your mic when you're done speaking. The agenda packets are in the binders, and just a reminder that you can take any of your agenda items with you, but if you can leave the binders with all the other background documentation, then Ann uses those for the next meeting, so that's helpful. And the remaining documentation, if we need it, it's on the Board of Health website under the meetings tab. So if at any time we need to look at the manual or anything else, we can find that online as well. Okay, so there was no public comment received before the meeting, but we have Mr. Joe Shogan from the City of Spokane to give us some public testimony. So, Joe, if you'd like to come up to the microphone right here. Oh, wait a minute, I don't see that. Shoot, it's not on our agenda, but we always start with the citizen comment.
Can you hear me?
Okay.
This is Patricia.
Too many meetings. Oh, I think I hear Patricia maybe calling in.
Yeah, I'm here. This is Patricia Keenholtz, Public Health Consumers. I don't know if you can see me. I can hear you, but I can't see anyone.
Welcome, Patricia. For the record, Patricia Keenholtz, board member, has joined us. Thank you for making it work, Patricia. Okay,
You bet.
now citizen input, and I was looking at the wrong agenda, so there you go. Joe, do you want to come up to the mic? Oh, just, I think there's a button there to turn on the mic. And then I forget, I'm sorry, we don't have it written down here. Is it 2 minutes or 3 minutes? 3 minutes, okay.
Real quick, I'm here on behalf of Dr. Steve Laney, who retired doctor from Group Health. And he was here at the last meeting. He's severely concerned about the impact of federal and perhaps state budget cuts on public health funding. And so I'm just taking notes for him. I too I keep up on these matters myself. And my wife's a nationally known speaker on issues of drugs and pregnancy. So I'm not a total neophyte, but so I'm just here to find out what the budget's going to be, are there cuts, state and federal, and what the impact's going to be on public health services. So thank you.
Thank you, Joe. All right, so board reports and chair report. I'll start with, I don't think we have anything since the last meeting. We had our executive committee meeting to plan for today's meeting. We don't have any action items on the agenda, as you can see, but we have a lot of updates and reports on the opioid treatment program, as well as budget forecasting and planning. So we will, I know there's probably some questions. I saw in the news just this morning that there's been some changes to funding at the state level that might trickle down to us. So I know we'll probably get an update on that from Dr. Thompson. So that's all for my report. committee reports. Mr. Cathcart with the Health and Education and Policy Committee.
Yep, the committee has not met since the last meeting.
Since I was not able to make the Budget and Finance Committee and you did, I will let you.
This was the agenda that I was looking at. That wasn't the meeting agenda for today, but it was the Budget Finance Committee. So we did a pretty deep dive in the Budget and Finance Committee, and it was board member Keenholz and myself, and we looked through, and the executive committee did this a little bit. The administration is starting to do a really good job of looking at every funding stream that's coming into the health district across and then, or down, and then what are all the programs funded by all those different funding streams? Because sometimes you have one program that's funded by 4, sometimes you have one program that's only funded by 1 funding stream. So you get a sense of the diversity of funding, and if one stream went away, what would that look like? So I just appreciate that Kim and Alicia are already starting to look through. Oh, there you are. I was like, where's Kim? There she is. Already starting to just get a sense of really, really down to each program, even staff persons at the health district and where their funding comes from, so that we can just be very knowledgeable as we plan for our budget this year with all the different could be changes at the local, state, and federal level. So that was a good exercise. And then had a little bit of an update on the treatment services, which we'll get today on the agenda. Okay. So the consent agenda is the item number 5 on your agenda. It's the meeting minutes from February 19th. The meeting minutes from, that must have been a committee meeting. Then we had the February 27th board meeting minutes, vouchers February 1st through 27th, and there was a minor correction to a voucher from the January 1st through 31st. Just a Scribner's correction on that. So I'm looking for a motion to approve the consent agenda.
I will so move adoption of the consent agenda.
Second.
Okay, motion and second. Any discussion on the motion? See none. All in favor say aye.
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 Any opposed? Okay, I think Patricia was an aye for the record. Thank you. So we'll move into our executive session, item number 6, and I'll let our legal counsel explain the reasons for the executive session and the time frame that we will be in executive session, approximately.
Thank you. So the board will be in executive session for approximately 45 minutes for labor negotiation guidance pursuant to RCW 4230-144B and litigation/potential litigation pursuant to RCW 4230-110-1I. For the first issue, we'll need the board members, Dr. Velazquez. I'm reading hand signals from Dr. Thompson. Dr. Thompson, and we need Danielle. There will be Evan Chin from Summit Law Group. And did I catch everybody? Awesome. I think that's it.
Do we need to announce who's in the second part of the, or you'll announce that at the time?
Well, I can announce it now. The second one will be the board members, myself, and Dr. Thompson.
Okay.
Can I just ask a question? What are the titles of these RCWs?
Well, Joe, we don't usually take questions from the audience, but I think that it's litigation, potential litigation, and labor negotiation.
I understand that, but,
Anyway, so we're gonna go into that executive session, and so the time frame would be if we
Start right now at 12:45. It'd take us to 1:30.
1:30. Yes. Okay. So we will extend if we need to, but we'll be in executive session till 1:30 p.m.
about whole person-centered care for perinatal opioid use. I'm the current president of the Washington Society of Addiction Medicine, also the chair of the International Women and Addiction Group, associate professor at the UW, and also an attending physician at our Swedish Addiction Recovery Services and a mom. I do not have any conflicts of interest. I'd like to start by sharing a couple of photos that were volunteered by two brave women in recovery. For the past few years, we have allowed people with living experience to be guiding us how we can do better. And as you can see here, the governors, Governor Inslee, created the opioid task force a few years ago and has been trying to improve evidence-based care, especially for opiate use disorder. A little bit more about objectives to focus on pregnant parenting people, discussing stigma, trauma-informed care, and the importance of evidence for medications for opiate use disorder. We do live in the fentanyl era. More than 99.9% of the patients that I see in my clinic in the hospital use fentanyl, mixed with a lot of other adulterants and substances. In the past, we used to have the fentanyl blue pills. Currently, it has been the powder and the rock, extremely lethal and extremely dangerous. This slide helps us appreciate that women continue to remain underrepresented in treatment. So we do have a call to action, especially in our Washington state. I'd like to start by addressing a few myths and truths that most commonly I get asked to. The first one is the understanding and appreciation that addiction just happens. We continue to see increased rates of opioid use, and as you can see here, over the course of many years and decades, women continue to be vulnerable and marginalized. Currently, we do see increased rates of opioid use of women in birthing parents and also women across the lifespan. The current Medicaid data does show us that a lot of people continue to increase their rates of opioid use, also includes newborns and families. In Washington state, we have Maternal Mortality Review Committee that does confirm numbers across our country that relate to opioid overdose impacting more than 10% of pregnancy-associated deaths. In Washington state, the rate has really tripled from 1.3 to 4.2. Also, 2 in 3 pregnancy-related deaths occur in the immediate postpartum period. 4 in 5 of pregnancy-related deaths usually are preventable. And among all pregnancy-associated deaths, currently between 11 to 20% are due to opioid overdose. More gruesome data to appreciate. 1 in 5 birthing parents experiences mental health or substance use. 75% of birthing parents screen at risk for postpartum depression and they do not receive treatment. 90% of birthing parents who screen at risk for substance use also do not engage in formal treatment. 50% of maternal mortality deaths are related to suicide and overdose. This is a public health emergency. We can also appreciate the financial burden of untreated mental health and substance use, especially fentanyl use disorder. The cost of not treating maternal mental health and substance use conditions, as you can see here, is $32,000 per birthing parent-infant pair and totals more than $14 billion nationally. That was 3 years ago. We are currently waiting to hear the current data, and we know that it will be more expensive. So our truth is that addiction does not happen. It is a public health emergency, and it is up to all of us, including you as leaders, to improve it. The second myth, addiction is a choice. There is a strong relationship between trauma, adverse childhood experiences, genetics, opioid prescriptions, as we saw on the previous slide, chronic medical conditions, and high-risk behaviors and addiction. Trauma is an event that could be single or repetitive. It contributes to chronic distress and trauma that interferes with how our brain works. Also, we know that poor physical and mental health, obsessive behaviors create chances for substance use and social dysfunction. This is a really good study as public health people to appreciate the adverse childhood experiences that was done by CDC and Kaiser in California. It highlights the importance of past exposure to adverse
Okay, what do you want to do?
conditions and maltreatment. Do you have a question?
No,
Should I stop?
just a minute. Patricia, could you put yourself on mute? I think we.
Yeah, I'm sorry, my mic is off and somebody just got in the car. I'll just be quiet.
Go ahead, doctor.
Thank you. Maybe I can take a minute and ask how am I doing? Please show me thumbs up if you would like me to continue.
No, sorry, I was talking to my partner who just got in the car. I'm in Montana, and I told him he could get in the car after the executive session was over, so I apologize for that.
No worries, Patricia. Thank you for attending.
Excellent. Go ahead, doctor. Thank you. This is great.
Thank you. Our truth is that addiction is not a choice. The ACE study showed that individuals who had more than 4 ACEs had 2 to 4-fold increase in poor health, tobacco, smoking, sexually transmitted diseases, 4 to 12-fold risk for alcohol, substance use disorder, mental health, suicide, high-risk behaviors, including opiate use disorder. So there is a very strong relationship of how we appreciate trauma, adverse child experiences that later in life directly impact violence, addiction, substances, and quality of life. The third myth, a lot of birthing parents and also health professionals believe that people need only detox. A lot of moms also share with me, Dr. Rudolph, I don't want my baby to be born addicted. That's all I hear from other physicians. Pregnant people who have opiate use disorder create opportunities to get healthy, to appreciate compassionate care, to discuss opportunities to get better, and also to receive evidence-based care that does not include detox only. Also, at this point, we know that newborns or fetuses who are exposed in utero for opioids, whether they are opioids with medications for opiate use disorder or illicit opioids, they are not born addicted. Evidence-based medicine allows us to offer standard to care, which is pharmacotherapy with medications such as methadone and buprenorphine, and not only to treat withdrawal symptoms. So our truth is that access to evidence-based treatment offers whole person care. A lot of people would say, if we talk to Dr. Sharisa Fatinos, she really works very hard to offer opportunities for no-door care, no wrong door care. We know in Washington state that we continue to be innovative in offering protocols and also evidence-based services for medications for opiate use disorder. We believe and we know that opioid detoxification, such as withdrawal management only, is not recommended, partially because it decreases neonatal birth weight. It also gives maternal birthing parent complications. The relapse chance rate is extremely high, up to 90%, and also it causes resumption of high-risk behaviors that later contribute to also overdose. As you can see here, relapse rates compromise not only the birthing parent quality of life, also the fetus, the newborn, and the family medicine, and the whole family unit. Opioid detoxification or withdrawal management is the beginning and a bridge to offering evidence-based care with medications for opiate use disorder. Reported success rates usually for people who are stabilized on medications such as methadone and buprenorphine is up to 82%, the same rates such as chronic diseases like asthma and diabetes. We already discussed that opioid use disorder is a chronic brain disease. It is very similar in its chronicity to diabetes or asthma. For asthma and diabetes, we take evidence-based medications throughout our life, recognizing that it is essential to decrease harm. Very similar is other medications for opioid use disorder. We try to meet people where they are, to offer counseling, education, to empower them with knowledge, to give them choices to choose medications, whether it's methadone or buprenorphine, different formulations. We also now offer split methadone dose. We have been working with SAMHSA and ASAM, and our Washington state is the very first in the whole country to educate patients and offer standardizing choice for split methadone dose. We also work very hard to engage in warm handoff care coordination, to offer close follow-up during pregnancy, postpartum, and across the lifespan. I try personally to celebrate the hard work of our patients, to allow them to feel appreciated for their resilience and hard effort. I'd like to share a person's story with you. This is a 25-year-old G2P0, a mom who never had a baby before, who was admitted to our Swedish Addiction Recovery Services unit. She had tried to stabilize on methadone in her OTP, opiates treatment program, for many months and was not able to stop fentanyl. So we admitted her to our program. We were able to offer high-dose stabilization for her, and she stabilized on 130 milligrams twice daily. We offered counseling. We also were able to dispense 72-hour methadone that was locked in a methadone locked box with bottles that were safely kept. We offered harm reduction. We gave her a Narcan kit that was dispensed, and she followed up with me for 3 days while she was taking her home dispensed methadone, and then she had an intake to her OTP, to her treatment program. She thought that the experience was very thoughtful, considerate, very practical. She was able to continue split methadone dose and stay healthy until her pregnancy, end of her pregnancy, and she delivered a healthy baby. Her methadone dose was 130 milligrams twice daily. This is 260 milligrams total daily dose. She continued to be healthy. As a matter of fact, she engaged with her baby. She was able to breastfeed, to offer skin to skin, to be there with her partner and the whole family. And her baby did not require any medications and did not develop withdrawal symptoms that required NICU or higher level of care or morphine. This is our study that we presented nationally and internationally. At Swedish, we have developed a compassion model that allows for 5 days after delivery to have the birthing parent, the newborn, family members, doula to stay on the postpartum floor for 5 days. For 5 days, we are able to stabilize on methadone, buprenorphine, to coordinate care, to work on mental health, tobacco cessation, postpartum analgesia, medical complications. For the newborn, we educate parents to breastfeed, to nurture, to engage, to bond. The whole family unit receives social work counseling, and we make extra efforts to offer care coordination. And as you can see here on the slides, no matter whether you're on split methadone dose, high dose, up to 150 milligrams twice daily, or whether you were on buprenorphine up to 24 or 32 milligrams daily, when you were able to be on the postpartum floor with the baby, with the whole family, the newborns did not develop withdrawal symptoms, were not transferred to the NICU. 92% of them did not require higher level of care. All birthing parents and families were able to discharge with their babies except for one mother, one birthing parent, who had a visit from CPS and she fled the hospital. She did not feel safe. In Washington state, we have been working with the legislature, the healthcare authority, on an initiative to allow us to standardize choices and evidence-based treatment for all 54 birthing hospitals and also all OTPs. We know that Spokane continues to be a leader. As a physician who works at Addiction Recovery Services, I was able to create a pathway for most of our patients who admit to us then to be able to follow up with you and your region. So we are working to standardize choices, evidence-based treatment, also to recognize that methadone and buprenorphine decrease harm and allows people to feel safe, to feel healthy, to have improved quality of life and satisfaction. We have created a peer-to-peer support line, as you can see here. This is a phone number for anyone who has questions to reach out to us. We also have a listserv, Yes We Can, northwest@gmail.com. And usually when patients ask, Dr. Rudolph, can we continue to be healthy and advocate for ourselves, they usually answer, yes, we can. My take homes for all of you is how we can work together to improve health equity and growth opportunities, to strengthen the amazing work that the Spokane region already has been doing, and how we can offer at the state level any help that you need to allow us to appreciate your work, your advocacy, the ability to save lives and to allow birthing parents to have new beginnings, to create miracles for their babies and for their families. I appreciate the inclusion and allowing me to advocate for our patients and also to express gratitude for all of you and your hard work. These are references. Thank you so much. And this is a time for me to stop sharing.
Thank you very much. Can you speak a little bit to how you coordinate then with our hospitals or our opioid treatment program here in Spokane? Is there any referrals that you make, or is that next on the agenda? Oh, you're looking at me, Dr. Thompson. That's going to be Iris. Oh. Okay. I think we have another presentation coming up.
Yes, and the short answer is yes. And the next presentation will tell you a little bit more about the care coordination. I'd like to reassure you that we have continued to advertise and highlight your resources and your region. And we at Swedish Medical Center and Addiction Recovery Services, we do offer referrals. And we have a really nice pathway.
Thank you, Council Member. I'm sorry, we don't take any questions from the audience, Joe, but well, you can chat with us after the meeting. I'm sorry, I'm going to take board questions, Joe. Michael?
Just real quick, back on slide 18, talking about the supports for the pregnant woman. You mentioned harm reduction, but didn't really explain what that meant. Could you describe what specifically was provided to her for harm reduction?
Yes, thank you. Harm reduction includes strategies to allow birthing parents to receive treatment, evidence-based treatment, at the same time to offer services that will decrease harm to anyone who is at the home. Our pathway allows for education on harm reduction, also giving Narcan take-home kits. The methadone that is dispensed is a methadone lock box, and we offer child and pet-resistant caps for any methadone that is dispensed. I also believe that it is the same for the Spokane Treatment Services program that you have in your region.
So the line specifically says methadone, comma, harm reduction, comma, OD prevention, and Narcan. So is there any additional things that were provided to her? You mentioned protecting people in the home. How exactly was that taking place?
Yes, thank you. Great question. We have developed after visit summary with resources and education on overdose prevention. We do educate the birthing parent. At the same time, we have resources and information that is also being distributed to the family members.
So it's just pamphlets, basically.
Pamphlets and Narcan take home, which is a medication to reverse any opioid overdose. So we dispense that free to every patient.
I have a question. This is Patricia. I'm really interested. First, I want to make sure that I have the slides. So I'm not sure if those were provided, but if we can get those, that would be great. I'm interested in what you were saying about newborns and fetuses not being born addicted. And I'm wondering if that is that just part of this study that you participated in or cited, or is that a broader discussion about neonatal abstinence syndrome and neonatal opioid withdrawal syndrome? So is the newborns or fetuses not being born addicted, is that associated with this split methadone use and these other methodologies that are being used, or is this something that was a myth and all newborns are not born with neonatal abstinence syndrome?
Patricia, thank you for asking the question. And in the past, for many decades, we would be bombarded with messages that newborns are born addicted if the birthing parent was treated with a medication or if the birthing parent was using illicit substances and illicit opioids. At this point, for the past 5 years, we have evidence that has been published by many different states, including also our state, to show that newborns who are born exposed in utero to opioids, they are not born addicted. They are born exposed to opioids, and the ability for the birthing parent, the mom, and also the whole family to engage in newborn care prevents the chance from developing neonatal abstinence syndrome and also neonatal opioid withdrawal syndrome. So this is the current evidence. As a matter of fact, we do have also Eat, Sleep, Console, which includes strategies to offer newborn care to allow newborns to transition after delivery without having any complications. I also would like to share with you that moms who do deliver babies who have been using illicit fentanyl, who never engaged in treatment, never were treated with methadone or buprenorphine, when they deliver in a hospital, their newborns have a much higher chance to develop neonatal opioid withdrawal syndrome and to be transferred to the NICU. So treating people with methadone and buprenorphine saves maternal lives. It also allows newborns to feel that they transition without any withdrawal symptoms. I hope this helps answer, and I can send a lot of resources. I was told that you will have the slides in advance and you would review them. I'm happy to send even more information if needed. Thank you.
Great, thank you.
Yep, we do have the slides, and then are those able to be uploaded for the public to be able to look at as well, right, on the,
They're currently on the website.
okay, perfect, because I know your contact information and links to more information are on there, so thank you, Doctor. Are we ready to transition? Okay.
Okay, and again, I think we're going to continue to go out of order because it would only make sense really to go to Iris next. And so we're going to go ahead and jump up to Iris's presentation. So Iris, are you ready? Yes. Okay. So, and you know, just to click the slide, and if you need anything. So now Iris is going to talk about our program in our treatment services.
Hello, like she said, my name is Iris Aleman. I'm with Spokane Regional Health District Opioid Treatment, and today I'm going to be talking about medications for opiate use disorder in pregnancy. So a little bit about me. I did obtain my substance use disorder license November of 2016. And, sorry, had to figure out which screen I'm looking at.
This is the next one.
Perfect.
What's presenting is that one.
Thank you. And so there's my husband, and I have two children, Luna Aleman, who is 7, and Luca, who just turned 3. And this is our pregnancy and parenting team. This is G. Hay Johnson. She's a DMP. We have Mary Burgum, MD, myself, and Isabella Bianchi, and she's a substance use disorder counselor, and she's here today as well. So our goal as the pregnancy and parenting team is to reduce the risk of overdose, trauma, abuse, overdose in postpartum, death in pregnancy for the baby, and also to reduce the NOWs, or the neonatal opiate withdrawal symptoms that the babies would experience. So myself and Isabella, we meet with our patients weekly, if not bi-weekly. It depends on where they're at in their pregnancy and what is going on. We really do concentrate on patient-centered, and that's what determines how often we meet with them. The pregnancy team does meet bi-weekly to discuss every single pregnant and postpartum individual on our caseload to determine if there needs to be a change in medication or of their treatment of any kind. When they do come to our program, they do get the option between methadone and buprenorphine. They have an assessment that's completed, or an intake, with the DMP or the nurse practitioner, and that is how it's decided which medication they will be on. Something that we do provide them is Narcan, because most of the time the women are still using. So this will help reduce an overdose, possibly. So when they do come to us, we do want to detox them off of the substance use and stabilize them on addiction medication. We send them to Swedish in Seattle or to the Good Samaritan Hospital in Puyallup. They are able to get them stable on either buprenorphine or methadone way faster than our agency would be, because they can evaluate them a few times in a day where we would only be able to do it once. Besides getting stable on the medication, they would also have OB care. And for a lot of these women, it might be the first OB care that they have contact with. If the women decide that they don't want to go, I do sit with them, and if they want to go to a stabilization center, I do refer them to Spokane Regional Stabilization Center. We would call together and get that set up, and they would go same day. So I do have a conversation with them regarding their pregnancy. Are they going to keep the pregnancy? Are they going to abort the pregnancy? Or are they going to adopt out? And we look at each of them, and if they're keeping, we give them a birthing plan. We develop a birthing plan and an aftercare plan as well. So when they get to go home, hopefully with their children, what is that going to look like? What is their support system? If they decide that they're going to go and abort the pregnancy, then we do provide them information on what is available and how much time they have before certain types of abortion is not possible or available to them. If they decide that they're going to do adoption, then we connect them with Mark Iverson here in Spokane, and we help them through that process. We do sign a release because some women just need that extra support, so we're there with them in their meetings to help them if that is their choice. So we provide them plenty of education. Every single session has different types of education, but the very first education that they do get is the pregnancy education, which is completed usually by G. Johnson or DMP, or our nurse practitioner who is addressing that. They do get information on how their substance use impacts their pregnancy and how methadone or buprenorphine can help them. We do provide them with information on breastfeeding as well. We make sure that they have wraparound services to address any barriers that they may have in their pregnancy and or recovery. We use agencies within Spokane Regional Health District, such as NFP, which is Nurse Family Partnership, or Safe Sleep. We connect also with other agencies outside of the health district, like Maddie's Place or Isabella House, which is an inpatient facility program. So we do let them know that when they give birth, the social worker at the hospital will do an assessment just based on that they are on methadone, and if their urine comes back positive for any substances, that will be submitted, and it'll be up to DCYF to open up or investigate. If they do, there can be a voluntary program which is not court mandated. The parents do agree to it, and they address any barriers to the safety of that baby or child. If they do open up a case, then it's a dependency case, and that is when the child can be taken away. So as I worked with these individuals, I noticed that these women aren't celebrated. So I connected with Yoshonda, and we were able to start the first the first baby shower. And this is pictures of the first baby shower that we did do. These women were so happy and grateful that we were able to provide these services there. They just didn't receive resources, but they were celebrated. And it was very exciting to see their face. And you can see. What grant gave us the money for this? Oh, this was AmeriGroup at the time, now known as Wellness Point.
So it's one of the MCOs in the region. I know Yoshonda Blunt is, yeah. So they basically sponsored this. That's wonderful.
Yes. And then success story, before I let you go, because I know that I'm close to my 7 minutes if I'm not over. I do have a 30-year-old female who has been pregnant 5 times. She recently lost her parental rights to 4 of her children. She did give birth to another child, and that child is CPS involved. However, she's been to our program 3 times, and this time around, you can notice the difference. She's engaged in services. She knows, as soon as she was pregnant, she knew that she was coming to our program, and she requested to work with me because she knows that we're gonna give her those wraparound services so that she is able to keep her child this time around. And you can tell because she is dosed consistently, we are way closer to having her stable. She's looking for a place to live. She's doing parenting classes. She's engaging in her individual sessions with myself. She's attending her medical appointments, which at the beginning was not the case. She had continued to use at the beginning. She had multiple restarts. A restart is when an individual misses 3 days or more of dosing on methadone. And when that happens, they have to come in, see the counselor, and get restarted. Then they have an appointment with medical staff to get started on their methadone again. But she is doing great. This time around, we were able to get her connected with an OB and a primary healthcare provider, and she has chosen to take or get an IUD, and she actually has it. She attended her 6-week checkup, which is something that she didn't do with any of our other pregnancies. So this is our success story. Thank you very much. This is my email in case you have any other questions. You can send them to me, and I know that Anne will be collecting questions if there's any to send over to me.
Excellent. Thank you so much.
You're welcome. Thank you, Iris. You did
I like the photos of the baby shower. That looked like it was a lot of fun.
Thank you, Iris. And Adam, why don't you come up here and don't look if this makes you nauseous. So, okay. And you know, I forgot to mention to everyone that that yellow tab that's in your book, it has the large printouts of everything that we've been going through. So Adam just wanted to present the new layout of the data that you're getting. He's also going to talk to some of the points that he wasn't able to get to last time about what you had asked for data in January, and point that out and kind of explain how this is going to be the database that you're going forward, and it includes all your data asks. And he's also going to talk a little bit about BI, what is it, Power BI, and then the dashboard that we're hoping to build in SAMS. Okay, this is Adam.
How's it going, guys? So one of the things that you had asked for originally was the referrals and to track them individually. And so now when they come in, they're filling out a first contact form so that we can actually get them fully built inside of ECR. So it'll track the day of contact, and if they come in repetitively, we have a spreadsheet that will track each of those days of contact. So now we can see in February we had 24 intakes turned away, but we were able to admit 6 of them during February. And so now that we're doing all of that work with the referrals, the days of referral to admit basically will become important. So how long before from when they showed up to when they were admitted. So this is averaging people that are coming in on the same day and getting admitted the same day, so you'll have a bunch of zeros. So that's why your average right now is 0.6. And overall, for the 2 months, it's 0.96. We discharged 34 people in February. We're still dispensing to roughly about the same amount of people, 967. Overall this year, we've dispensed to over 1,000 unique individuals, so 1,009. Courtesy dosing, so people that were dosing for other clinics from other clinics in all over, essentially, is 81 total for this year, 60 just in February. A lot of methadone goes out on just over 29,000 doses and 184 doses of the generic Suboxone. Still doing a lot of counseling, 697, which for a shorter month works out. So done almost 1,500 just counseling sessions in the first 2 months. A lot of groups, averaging about 100 a month, so 211 overall this year. Still seeing people for their annual physicals that we're required to do 1 per patient per year, besides their intake physical. and we completed 42 assessments. For jail, we've done almost 700 doses in February, 1,400 overall, and it looks like we dispensed to 38 unique in February. We're averaging about like 20 to 25 people per day that we're taking over doses for. This format should be what you see every single month going forward, so you'll see the same data over and over again. Wendy came up with this layout, so it'll be nice and easy for you guys to see, and it looks great. The data comes from two different places. It comes from Power BI that I have to pull data out of that their reports inside of ECR do not pull, and so I have to combine all of those two data points into the spreadsheet that you're seeing here. And the dashboard, we're hoping that will just pull all of this data and take less overall hard work, essentially. Hopefully SAMS will be able to just build that dashboard into their system itself.
And just to clarify, that's the new electronic
The new
record system,
EHR.
SAMS.
Yep.
Okay.
Yep.
So this will, once SAMS gets fully up and running, it'll be much easier to pull the data and put it into a dashboard, is what you're saying?
Mhm.
Okay,
I'm hoping it'll make it easier overall.
great.
And so as you continue to want more, more data points, if it's possible, we want to accommodate your data requests. So let us know if you have any other data points that you would like for us to see if we can get those for you.
Especially when we're in the building phase in the beginning, get them to integrate it in.
And I was just gonna say, as I know with SAMS, it's gonna give you more internal information about number of patients seen, the turnover, how many assessments are being done every day to know. So if you have goals internally, right? Oh, we want every counselor to try and see X number of patients each day or assess this many people each day. It'll be easier to set goals or expectations once it gets up and running. Because this right now is numbers, but what is the context, right? Is that at some point internally, you will help set some goals for the staff, right?
Right, and actually, through Power BI, Adam does have the capability of running the individual employees' stats. So this is a roll-up, an overview. And so he can run the stats individually by employee, and that is part of how the managers over the counselors, they do part of their quality assurance and quality assessments of the counselors' work.
Councilmember Cathcart?
Yeah, just maybe for Dr. Thompson, I'm not sure, but on the first intake, so intakes turned away, total 28, returned and were admitted 6. So is that a net of 22 that were turned away then? And then do we know kind of what the reasons were?
So what that intake's turned away is they were just purely turned away. It doesn't count that those 6 were admitted on. It's just saying we turned them away for services that day.
But do we know, so were those folks that are not existing patients, or they were trying to become patients, or what, do we know?
Of what the intakes are?
Yeah,
They
well,
could-
of those, the 28 people that were turned away, were they turned away because they're not existing patients and there wasn't time and resource, or?
The most common reason they're turned away right now is due to low staffing. So whether it's ARNPs or counselors or whatever it is that day, we just don't have enough spots.
And if you recall, they implemented a new process where when someone comes in and they're going to be turned away, they go ahead and give that person a medical record number so that when they come back again and we are able to get them in, they already have a medical record number and we can track whether or not they had been turned away previously. And so what that 6 means is that they had been given a medical record number and had been turned away, but now they've returned.
So they could have come in November, or December, and then returned, and that's how we counted that.
Well, from the time that we started that new process.
Because we started it February 4th.
February 4th.
Okay, so those
Yeah.
6 were folks that came in February then?
Yeah.
Okay, so a net of 22. So we've had 22 individuals who are not able to access services. Okay.
That's great. I'm glad you are doing that, because you wouldn't be able to collect the data unless you gave that person that number to know if they came back, right? Okay.
Yep, exactly.
Well, this is great. I think it's a great start, and if there's more data that we want to add to it, that'll be a great,
Just let us know.
yes, thank you.
Thank you.
Okay, and then real quick, we'll back up. Just wanted to, again, look at the tab in your book. There's a bigger spreadsheet, but the bottom line is this is the final for the year 2024 end. We ended 2024 in treatment services with a surplus of $865,549. Then for 2025, we closed February, and so for January and February, we have a surplus of $261,521. Okay, and then we're going to zoom forward. Actually, I don't think I have. Do I have a slide for the next item, which would be? No, I don't. The next item would be the expansion of treatment services that was announced in the newspaper. And so I was asked to speak on that. And I don't know if Commissioner Cooney, if you want to say any words or if you just want me to speak to it. Yep.
At the county, we are looking to partner to get more individuals treatment and services. And so, since we're already contracted with Spokane Regional Health District, it just seemed that that would be a better way to do it. I think one of the things that I'm hearing is, if we don't have enough staff, I mean, we've got to look at that. So I mean, so this is just a possibility that we'd like to participate, and then also. For turning people, there's just several things as we look to this, addition is if there's not enough staff, if we're turning people away now, how do we do all those things? So
right, and so quite a while back, I don't remember exactly how long, I had a phone call from the county. From Justin Johnson, and he just said, I've been talking to the city and the county about using some of the opioid settlement funds, and if we're able to work this out, do you think you would be able to use it to expand hours and access to assessments so that you wouldn't have to turn anyone away during the hours that you're open? And I said, sure, we'd be open to trying to figure that out. And that's pretty much the information that I had. And so, yes, sir.
Yeah, I mean, I guess, and I requested that we talk about this and still think maybe further discussion is warranted. We don't have a lot of time today. I just would like to understand, I mean, you talked about the surplus that exists, and I don't know if you were referencing that the 850 rolled over and we've spent that down to 250 or what exactly that bottom line number is. But regardless, there's a surplus there, and that's sort of one-time money. And then you're talking about one-time money from the county and the city potentially. And I would just like to understand how staff could be expanded in a way that would accommodate additional hours, additional patients. How many patients? I mean, we talked about 22 for the first 2 months of the year. And to what extent would those dollars be effectively spent, and what sort of impacts would that have on the sustainability of treatment services if they are one-time dollars?
Okay, so We are a fee-for-service provider, and so this surplus, this 865,000, typically what happens to that surplus is it gets rolled into the general fund. We, as of now, Treatment Services has no access to that money. It's rolled into the general fund of SRHD, okay? This excess, this 261,000, that is, that's how we're running right now in 2025. And that's our 2025 budget for our current level of service. And so what my understanding of the conversation is that the city and the county are talking about using some of their opioid settlement dollars to expand the contract with SRHD so that we can use those dollars as kind of to launch more hours, be open on Saturday, be open later hours during the week, so that people who want to access us can access us. We can bring on the workforce that we need, because what happens right now is we in order to accept all those walk-ins, we have to have every single category of worker available at Treatment Services. Because when a person is ready to go into treatment and be assessed, we have to be able to do the psychosocial. Do you want to help me,
Right,
Isabel?
no, Dr. Thompson, I understand all the
But-
services that go into it, but how do you sustainably hire staff if it's one-time
So I
dollars? That's
think-
the crux of
We
the question.
bill for services. We get paid.
So what I'm hearing you say is this money, if the city and county wanted to contract
Yes.
further, that this would be kind of startup funds to hire
Yes.
some additional staff to start seeing more patients and more
Yes.
hours, and then
And
you'd
then
be
we
able
bill.
to bill, and that would be the sustainability
Yeah.
mechanism for
Yep.
the
Just
agency.
because right
Okay.
now, you can see we're running in the black with our current services. And if we expand services, we expand hours, we're able to take everyone that is ready and keep them in our program, then we would be billing for services and we would be bringing in more money.
And how many patients do you believe we'd be able to expand?
That's a crystal ball question that I can't answer.
Again, I'm just trying to get to the effectiveness of the dollars. I can't get answers from the city side, so I'm trying to get answers here and trying to understand, is this the most effective way that we could be spending those dollars to help with addressing the fentanyl crisis? That's truly what I'm trying to understand.
Right. Well, I know that we didn't start tracking how many people we turned away until like the very end of June last year, and we turned away 224 people. And I don't know how many of them came back and finally got in. And, so that's like, you double it, it's somewhere 500.
Okay.
I don't know,
So I guess the next step would be that you're gonna have further conversations with Justin and the city, and there'll be a proposal made of the dollars and how many staff would be needed to hit certain goals around serving folks in the community, right? So is that the next step?
Well, that's the next step. We would be the people that the city and the county would come to and say, here's because we're not actively pursuing this. So I'm just waiting to hear from the county.
Yeah, I think, yeah, and I know Justin's been working on it. Go ahead, Mary.
Yes, I think that's, I'm not sure all the communications that have gone on. So if that's where you guys are, because I do think that you guys had put together a budget
We
for,
did.
for Justin.
Uh-huh.
So that way we would know how much the numbers are. So, so you guys have produced that.
Yes, we did.
And then that's what we're looking at to see if we need those additional funds. And I think it's a discussion that we could have at a different time on the reserves that are now coming up, because it's a matter of, you know, if it's a fee for service, are there ways then with what you know is the surplus that is coming in to then be able to use those funds within, you know, with using those additional resources within treatment services to be providing additional services. I think that's really the crux of what Commissioner or Councilmember Cathcart's trying to ask. And I think we all have to ask that, because we've got to make sure that we're doing the best thing with these dollars for the public, and still doing the services. So I think it's a further discussion for us to talk about what those reserves could be doing within treatment services to be serving more individuals.
Question, does that budget include hiring a psychiatrist over at treatment services, or, you know, is it just expanding hours, or is it increasing social services that aren't just for methadone?
Right now, it's for maintaining the services, because the same services that we have, because we've continued to have conversations, haven't had one for a few months with Budget and Finance Committee about our mental health treatment program, and the board had asked us to hold on filling any vacancies in that program. And so no, we did not include any positions for the mental health treatment program in that budget.
So it sounds
Is
like.
it possible to do another one that would include meeting all of the goals that they want to have over there, with expanding, you know, to having a psychiatrist there and having some counselors added to that, so that, I mean, if it's a fee for service, if you have a psychiatrist, that's a fee for service. That if we could figure out how to pay for the psychiatrist to begin with, then maybe we could continue to be able to pay for that even with the reserves. So I'm just trying to meet some of the things that were mentioned to me when I went over there.
Okay. Thanks, Patricia, for bringing that up. I know that's important, that there's been a desire to grow the mental health counseling side. So something to consider. Commissioner Kearns?
Well, and also it's reducing their costs because they have to go outside for their prescriptions. So the psychiatrist having one there allows them to prescribe in-house.
Thank you. Commissioner Kearns?
One of the questions that I asked Justin Johnson when he presented to us was, so his whole concept that this would allow the organization to bring that number down of individuals that are turned away because, you know, there's a walk-in, there's nobody to work with them, so they're turned away. My question for him, and he didn't have an answer for it, was if these new staff members are, you know, if we're staffed up to target that population, what sort of assurance is there that those folks' calendars or schedules don't get filled up with existing clients, because now the organization in theory has more capacity to schedule more appointments with folks coming in for their doses, to where we end up right back where we are, where they're helping existing clients and then people start getting turned away again.
That would be a wonderful problem. I'm sorry, but that would be a really wonderful problem.
But then again, we didn't fix the problem. We
Well,
still are turning
well,
people
but
away.
we would be treating a lot more patients. That is something that, as we're looking at the scheduling and the staffing of the expanded access to assessments, that we will need to keep in mind and continue to grow. And as we, and this is going to be something that the board's going to need to think about, because as we've gone through the past, and we're only at 2 months into the year, but we're ahead in our budget at 261,000. If we start approaching that, and it looks like we need to actually increase our staffing even more, we'll need to ask the board to increase our staffing, and we'll need to ask to use some of our surplus to increase our staff, which in turn will increase our fee for service and our revenue that we generate, right? But in the past, it's been, well, you have to show us that you have the money before we can approve new positions. So.
But I see your question, and maybe,
Yeah, I'm just trying to get a
Yeah.
clarification. So at least the way Justin presented it to us, my takeaway was that these new positions would be focused, or would at least prioritize
That's right.
walk-in.
The drop-in.
clients.
Absolutely.
Is that the way you are envisioning it too?
Yes, absolutely.
Okay. Thank you.
Absolutely.
and especially if it's like a Saturday situation, it would really just be for the walk-ins. You
Yep.
wouldn't have any other standing appointments for
Right.
people that are already on the services, for
Right.
instance. Okay.
Right.
Well, it sounds like a really great opportunity to partner, all of us, city, county, health districts. So we will just be in conversation with Justin at the county, and as the numbers get further crunched, I'm sure there'll be a presentation, and it'll have to be approved by both bodies, the city and the county, to move forward with an updated contract. So we'll stay in touch on it.
Yeah, wonderful.
Okay.
And this is, sorry, I need to zoom to the very end of the presentation, because you had also asked for the client satisfaction survey results from treatment services, and that is also in your packet, and you have that in your packet. And so I'm not going to delve into the results.
Thank you for
Okay.
following up on all of our questions.
You
Appreciate it.
bet. You bet.
So we are at 3:15, or almost, 3:14, 13.
So what
It's-
would you like to do?
Well, how many board members can stick around for another 15 minutes till 3:30?
I have a 3:30.
Okay, so we need to head out.
10 at most.
Okay. Okay. Everyone's adjusting their schedules because we went so long today. And we didn't even have any actual voting action items. And we really tried to push things off. So could we, what other things do we have on your agenda? Have you gotten through your report? Okay. Dr. V, could you give us a very brief 10-minute update from any health and disease updates? And then I think we'll need to close the meeting then.
I can actually do it in 3 minutes.
Oh, my
How's
goodness.
that? I'm not going to go through all of the slides. I'm just going to pull out a couple of things. So number one, respiratory illness is going down. Pertussis is going down. Shigella has gone down. We have 463 total cases of pertussis as of yesterday, but it's tatering down. The measles outbreak is up to 378 plus in 18 jurisdictions. If you look at the slides from the last month at Michigan, Ohio, and Pennsylvania, there have been 2 cases in Washington State, one in King County, one in Snohomish, and one in Snohomish is related to the one in King County. We have no cases here, but the team is already engaged and ready for response if needed. And one of the things I include in your packet is communication we've had with our partners, including K through 12, which is being released in their spring newsletters for spring break travel, making sure that folks are aware of measles in other parts of the country and other parts of the world, including Canada. So in addition to that, in your packet, I put some community collaborations. I want to call your attention to the one under Fentanyl Roundtable, and the preamble to that is last year, State of Washington had a study that suggested that young people who exit behavioral health inpatient treatment services are the largest group of people who become homeless within 3 to 12 months of all young people. So one of our partners of the Fentanyl Roundtable, which is North Star Advocates, and one of the key members of that is Sarah Spear. Sarah Spear chairs our post-system care work group that has been working on what happens after treatment with individuals. We're happy to announce that a bill was passed recently that allocates some funding for a program that is called Post-Inpatient Housing Program for Young Adults. And this program will be available for people aged 18 to 24 who are exiting inpatient behavioral health treatment or have exited behavioral health treatment and are engaged in recovery. There will be at least 2 residential programs under this pilot project, one on each side of the state. And we're very pleased to announce, and it's in your packet, that Spokane has been selected at the site in the eastern part of the state. And Excelsior Wellness is a partner that will manage this particular program from the Healthcare Authority. Is $1.4 million, about $250,000 for behavioral health components, $50,000 flexible funding program for residents, and there will be facilities between 6 and 10 beds. So that will address one of the biggest drop-offs. We have young people once they exit some of the treatment programs. I'm going to stop here and see if you have any questions.
Thank you for providing the packet up front. I just was flipping through it, and great updates. Let's hope that we don't have any measles cases here, and we can continue to be prepared. So
we hope so. We had one last year, and we circled around it, and it was only one. So
that's great.
Everything in your packet. So I do want to say thank you to all our partners in the Fentanyl Roundtable, because quietly we keep working and getting things done. So thank you.
Thank you.
That was about 4 minutes.
Okay, that was 4 minutes. So I know we had a legislative session update that's in the packet, and then it's also National Public Health Week coming up. And you just have a few slides, Kelly, to talk about, right, in terms of just what's going on, so we can all be aware as board members and help promote what's going on that week. I think there's only about 3 or 4 slides. So I just wanted to make sure everyone was aware. National Public Health Week, April 7th to the 13th. And if there's anything we can do to help promote it as a board?
Absolutely.
Okay.
You could all jump on your social media platforms and talk to my colleagues in your organizations about sharing the messages that we have, and even sharing stories about how you work with public health or how public health works with your different entities. That would be very helpful. But really the gist of is public health starts here. That's the theme this year. And so we have been, I'm missing. Yeah, so one of the things that we did was take some lessons, and I think it's in your slides. Do you have a slide that says De Beaumont? Yes. Yeah, so the gist of the De Beaumont information is just talking about public health. How do we talk about public health these days when post-COVID and when there's a lot of divisiveness in the community about it? And so really centering it on public health workers are here to serve the community and to help everyone have an equal chance of reaching their best quality of life, and that public health workers are part of the community. So what we're trying to do this year is really take a look at real people that work here in public health. So this slide shows who's in here. We've got Josh. Josh is in case management. So we mentioned that, but we also mentioned that Josh's band plays at Pig Out in the Park every year. So he's really part of this community. We also have Trisha, who is measuring the ladder. Did you know that we do that? Make sure that your children's head doesn't get caught in the ladder at the playground. So there's a lot of things that we do that And we're your neighbors, we're your family, we're sitting on your PTAs, we're part of the community, and there's just a lot of things that you maybe don't notice that public health does, and so I'm trying to highlight that with our messages. Also, being a part of the city, making sure that the city lights up as blue, putting Gumby on the clock tower to look over the entire community. Our building will be lit up as blue. I don't know if you've noticed, it's a brighter blue because we got new lights. Also involving all of our community, all of your agencies. We have proclamations planned with the City of Spokane Valley, and Spokane County. Also, I talked to my own colleagues and to everybody out in the community, and this is just an example from last year of the community sharing our posts and celebrating Public Health Week with us. And then, of course, we have an activity here at the Health District. If you guys are wanting to come by, the pictures are because we're going to have a trail mix bar. All of the employees pitch in, and we always have some snacks and goodies during that time. But hosting is the first floor, so it'll give all the staff an opportunity to come together and learn about other programs in the district. And the first floor with their new offices and their new areas, they're really excited to be able to show that off as much as they can. But it also includes syringe services and vital records, and facilities even is a part of our open house, so we can learn about some of the work that they do. And it just helps us get to know each other. So that's everything that we're doing. There we go. Do you have any questions? Also, the marketing that you saw is in newspapers, digital marketing, social media, and we have a PSA that we're sending out to the television stations. So,
Great.
yeah.
All right. Thank you, Kelly. And I know we have to head out here, but the legislative update is in the packet. Were there any questions for Lola about any of the bills that she highlighted? I appreciate you, Lola, putting a little more detail about which bills Wasalfo is supporting, which ones are consistent with our SRHD legislative agenda. So thank you for doing that extra to make sure it's easy to follow. Appreciate it.
Absolutely, yeah. I also wanted to just let everybody know that by about 1:30 this afternoon, a good third of the information on the notes has changed. So what you have is not as, I think it's as good as last Friday afternoon. What I have is as good as this morning.
Would you be able to update this and send it out tomorrow, just with the changes that happened today? So
Yep, you read my mind.
looks like you already had a cheat sheet. So
I did, yeah, you read my mind. We will also have the Wasalfo meeting tomorrow afternoon. So what I would like to do is not only share with, if I can wait until Monday so that I can present to you both the Wasalfo updates as well as my little cheat sheet note that I keep track of the things that we've been talking about directly in the presentations. That way it's all together at the same time.
Okay, so we'll look for that update on Monday.
On Monday morning.
And Dr. Thompson, we did receive at the county some analysis of some of the cuts that were, some of the changes to the grants from the federal to the state from Justin's perspective. I think some of the SAMHSA related grants. Would you be able to send out after this meeting any updates that might impact us for changes for those
I sent out
dollars?
an email
Oh, did you?
to all of SRHD. So I thought I'll send it out specifically to the Board of Health, but there was only one COVID funding stream that impacted us, and it was our vaccination program, and it had minimal impact, and we had actually, it had no impact on staff. The primary impact it had was on our advertising for respiratory illness.
Okay.
And so
marketing around that. Okay.
yeah, and so I will forward that email out to Board of Health members. Okay.
Thank you. All right, thanks everyone for staying later. We are adjourned.